Okay, now we are switching gears and going into chapter 45, which is urinary elimination. And we need to know about urinary elimination because it's an important part of our normal bodily functions. We know that urine removes waste from the body, and when there's alterations to urinary elimination, patients can have negative outcomes because this urine is going to not be able to exit the body, and it can, as we know, it's a waste product, so it's a waste product building up in the body. It's important to know the reasons for urinary elimination problems, such as UTIs, retention, different kind of problems we're going to talk about. And it's important to understand how the patient's needs need to be met when they do run into any issues with urinary elimination. So this slide, we're going to talk about the scientific knowledge behind it. We know that our kidneys will remove waste from blood to form urine. We have our ureters, which transport the urine from the kidneys to the bladder. And of course, we have the bladder, which is the reservoir for the urine until we have an urge to urinate. And then we have the urethra, which is where urine travels from the bladder and exits through the external meatus. And we know that elimination all depends on the functions of the kidneys, ureter and bladder, and urethra. As mentioned earlier, kidneys will remove waste from the blood to form urine, and the ureters are going to transport the urine from the kidneys to the bladder. And the urine leaves the bladder through the urethra, which is the area where we would insert a Foley catheter. All organs of the urinary system need to be intact in order for this to be successful and for our body to successfully eliminate all the waste. We have efferent and afferent nerves that go from the bladder to the spinal cord, and that needs to be intact in order for the urge for urine to develop, so that you need to have intact efferent and afferent nerves. This diagram here is just showing you the location of the kidneys, the bladders, and it's giving you a view of the nephron. We know that our kidneys will lie on either side of our vertebral column, behind the peritoneum and against the deep muscles of the back. Our kidneys serve as a filter for our body, all the waste products of metabolism that collect in the blood. The blood reaches each kidney by the kidney artery that branches from the abdominal aorta. The nephron, which is a functional unit of the kidney, it's a picture on the right. That little nephron is the one that actually forms the urine. And this little nephron has a glomerulus, a Bowman's capsule, a proximal convoluted tubule, a loop Henle, distal tubule, and collecting duct. A lot of parts to this little nephron. Ureters are little tube-like structures that enter into the urinary bladder. Urine drains from the ureters into the bladder and is sterile. And we usually say urine, as long as it's inside the bladder, is still sterile because it's all internal. The ureters enter this little obliquely, kind of like in an oblique section, into the bladder wall. This arrangement prevents the reflux of urine from the bladder into the ureters during the act of micturition by compressing of the ureters at the ureterovesicular junction. And obstruction within a ureter, such as a kidney stone, results in strong peristalsis waves, which is usually what causes that pain. So these waves are very painful and can be called renal colic. The urinary bladder is hollow, and it's a muscular organ. It stores and excretes urine. When the bladder is empty, it lies in the pelvic cavity behind the symphysis pubis. And when it's full, you can actually palpate the bladder and feel if the patient is having retention, and you palpate the bladder, you can feel that there's urine in there, and you can tell that there is retention going on. And of course, we can always do a bladder scan as well. When the bladder is full, it expands and extends above the symphysis pubis, and we can see that it can be distended, and it can even reach the level of the umbilicus. Urine will exit the bladder through the urethra, pass out of the body through the urethromeatus. Normally, there's like a turbulent flow of urine through the urethra and washes it free of bacteria. There's mucous membranes that lie around the urethra, and urethral glands secrete mucus into the urethral canal. There's a lot more detail in your book, so make sure you do read that section just to refamiliarize yourself with the anatomy. It will help you understand some of these disease processes. Here is a knowledge question. A patient with a long-standing history of diabetes is voicing concerns about kidney disease. The patient asks the nurse where urine is formed in the kidney. The nurse's response is, the correct answer to this is a nephron, since we just discussed that the nephron is the part that's inside the kidney that actually makes the urine. So it's the nephron, not the bladder or the kidneys. It's actually the nephron. Additional kidney functions. Oh, and by the way, I'm skipping the case studies because as long as you go over this PowerPoint and you want extra practice, feel free to go over the case studies. But for now, we're just going to go over the other slides. We know that our kidneys do other functions. They filter blood, which is their prime function, and they also create erythropoietin, which is essential to our red blood cell production. That's why many of your dialysis patients will be anemic, because they lose the ability to produce this erythropoietin because their kidneys no longer work. And erythropoietin, what it does, it stimulates the bone marrow to make more red blood cells and makes our red blood cells last longer. And a longer red blood cell stays in your body functioning longer. But when it dies off quickly because it doesn't have the erythropoietin, then you have less of them in your body, which causes you to be anemic. They also produce renin, and as we know that renin is a hormone, and prostaglandin E and prostacyclin, all of these affect the blood pressure. Renin is usually the one that starts the chain of events that causes water retention, and it increases the blood volume. That's why some of your antihypertensive drugs eliminate this. They break the cycle, so you do not have water retention, because as this says, it increases the blood volume. When you have less blood volume, you have a reduction in blood pressure. And also, when your kidneys aren't working, you have an effect on your calcium and phosphate. So the way the kidneys affect the calcium phosphate regulation, and it's because by producing a substance that converts vitamin D into its active form, patients with chronic alterations in kidney function, which is like your kidney failure patients, they don't make sufficient and active forms of vitamin D. They're usually prone to develop renal bone disease, which can cause their bones to become demineralized, which impairs the calcium absorption. That's why if you've taken care of kidney patients, you notice that you'll give them Foslo, and you give them other Renvela to help absorb this from their meals, because theirs is impaired because of this reason. And as far as your renal hormones, which is your renin, prostaglandin E, these affect the blood pressure, as mentioned before, regulation in several ways. In times of renal ischemia, when there's your kidneys feel that reduction in blood flow to it, renin is released from the juxtaglomerular cells. And like I said, your book has some really great information on this. Here's another diagram showing you the ROS system, what we call the ROS system, renin-angiotensin mechanism. So the physiological effects of this renin-angiotensin mechanism What happens is renin functions as an enzyme. It converts angiotensin, which is a substance released by the liver, into angiotensin 1. Angiotensin 1 is then converted to angiotensin 2 in the lungs. 2 for lungs, you have 2 lungs. Angiotensin 2 causes vasoconstriction and stimulates aldosterone release from the adrenal cortex. Aldosterone causes retention of water, which increases your blood volume. That's why you have your blood pressure medications that stop this cycle. The kidneys also produce prostaglandin E and prostacyclin, which helps maintain renal blood flow through vasodilation. These mechanisms increase arterial blood pressure and renal blood flow. So this mechanism occurs the moment the kidney feels that there's less perfusion going to it. So it enables the raw system to help with retention of water to help you keep volume in your body. Now the act of urination, and also known as micturition. We have voluntary control from higher brain centers and involuntary control for the spinal cord that influence the act of micturition. There's brain structures that influence the bladder function. That would be like your cerebral cortex, your thalamus, your hypothalamus, and brainstem. These all work together and they inhibit the urge to void or allowing voiding. Normal voiding requires the contraction of the bladder and coordination, relaxation of the urethral sphincter and the pelvic floor muscles. That's why sometimes we show people to do exercise if they're having incontinence of urine. It's very important that as nurses we understand the process of normal voiding and are able to assess and determine what is incontinence and when bladder problems are occurring. Normal bladder usually holds anywhere from 600 to 1,000 or 1 liter, 1,000 mLs. And the average adult normally voids every 2 to 4 hours. Most of us don't void that often, but if maybe 4 hours, but 2 hours seems a little excessive, but that's, your book does talk about 2 hours. It's usually more towards your elderly population, but the middle-aged population will void anywhere from 4 to 6 hours. And as the volume increases, the bladder wall stretches, sending sensory impulses to the micturition center in our sacrospinal cord. Incontinence is usually classified when someone has lost a function to hold their urine. So they'll usually have a lot of stress incontinence, or they'll just have many accidents. And there's women who are incontinent after having children. As they get older, they'll suffer from incontinence, and many of them will wear peri-pads for them to allow themselves to stay dry. If there's damage to the spinal cord as well, we lose the reflex that connects to our brain to let us know that we need to void. So we lose that voluntary control of urination. And if someone with spinal cord injury loses this, they usually have to self-catheterize. They're taught to self-catheterize every so often. If there's chronic obstruction caused by some form of neural damage or prostate enlargement, all of this will affect voiding and emptying of the bladder. Overflow or incontinence makes the bladder remain full, and there's pressure that exceeds sphincter pressure, and it can result in involuntary leakage, which is usually what happens to people with incontinence. Head injury and such things like multiple sclerosis as well, diabetes, trauma to the urinary system, and after someone's sedated, which is when someone's going to surgery, which is why we put a Foley catheter, because they're going to lose that control of being able to know when their bladder is full. They lose that, so there'll be leakage. Hyperflexia, I don't know if you've heard of that term, but what hyperflexia is a life-threatening problem. It affects heart rate and blood pressure. and this is usually caused by an overly full bladder, but it's neurogenic, and it can be caused functionally by blockage. So that's hyperreflexia. Factors that influence urination. We have disease conditions and procedures as well. So socioeconomic factors will determine the degree of privacy needed for urination. Not everybody can void in front of someone, so sometimes people need privacy. Psychosocial, if someone's anxious or stressed due to privacy issues. The kidneys primarily maintain the balance between retention and excretion of fluids. You can at times have patients that have different urinary disturbances. Some of them is nocturia. We know that nocturia, nighttime, is awakening to void one or more times during the night. Polyuria is an excessive output of urine, which can happen with your patients with diabetes insipidus, or newly diagnosed diabetics also have excessive urine output. Oliguria, which is a decreased urinary output in spite of adequate fluid intake. And anuria, which occurs when the kidneys produce no urine. And then there's diuresis, which is increased urine formation. If someone has a fever, it can cause an increase in the body metabolism and accumulation of body waste. So although urine volume is reduced, it is highly concentrated. That's why sometimes doctors want to have urine collections that can show the amount of concentration. And more diseases affecting urination. There is a pre-renal, renal, and post-renal classification. There's disease processes that affect urine elimination and the act of urinary elimination, or both. Conditions that affect urine volume and quality are generally categorized as pre-renal, renal, and post-renal in origin. There's usually decreased blood flow to and through the kidney, pre-renal. Disease conditions of renal tissue and obstruction in the lower urinary tract that prevents urine flow from the kidneys, which would be your post-renal, sometimes after alter the renal function. The conditions that lower urinary tract, including narrowing of the urethra, altered intervention of the bladder or weakened pelvic and peritoneal muscles, all of this can affect urinary eliminations. Things such as diabetes, neuromuscular disease, multiple sclerosis, all this changes the nerve function that leads to the loss of bladder tone or reduced sensation of the bladder fullness or inability to inhibit bladder contractions. Older guys or older gentlemen usually will suffer from BPH, which is benign prostatic hyperplasia, which makes them prone to urinary retention or incontinence. Some patients with cognitive impairments, such as Alzheimer's disease, they lose ability to sense a full bladder and are sometimes just unable to remember how to pee, so they'll be incontinent for you. There's diseases too that slow or hinder physical activity that can affect the ability to void. Such things as joint disease, Parkinsonian are examples of this. Some diseases are irreversible if let's say a patient that goes into shock and has acute renal impairment. But then you have diseases that cause irreversible damage to the kidneys and will result in end-stage renal disease. If someone does go into end-stage renal disease, we know that they're going to have a lifelong requiring dialysis or may have to be transplanted with a new kidney. And there is such a thing when it comes to transplantation, that you can be what they consider a live donor, which is you donating to maybe one of your children, a parent. I had a student before who was a live donor and a faculty member as well. So people can live very good lives with one kidney. Just make sure that you always take care of the one kidney you have, because if you lose that one kidney, then you yourself are going to find yourself in an end-stage renal disease situation. So if someone goes into end-stage renal disease, it's usually can happen if it happens acutely. It can result into what they call uremic syndrome, which is an increase in nitrous waste in the blood, marked fluid and electrolyte abnormalities. I'm still talking about end-stage renal. Sometimes these people will have nausea, vomiting, headache, coma, and convulsions. As the uremic syndrome gets worse, aggressive treatment needs to be done in order for the patient to survive. That'll be like emergency dialysis, especially if the patient is having an increase in potassium levels. And dialysis can be broken down into two different forms. It can either be peritoneal dialysis or they can be hemodialysis. And the difference between the two is that peritoneal dialysis is indirect method of cleaning the blood and waste product. It uses osmosis and diffusion between the peritoneum. So it uses the peritoneum as a semi-permeable membrane. This method removes excess fluid and waste products from the bloodstream. When a sterile electrolyte solution, which is diacylate, goes into the peritoneal cavity by gravity usually, and the patients usually will have, they will have a catheter that extends out, and they connect themselves to this machine that will have this diacylate go into their peritoneal cavity. The diacylate stays in the cavity for a certain amount of time and then it's drained out. And because it causes osmosis and diffusion, the waste product will accumulate, and excess fluid and electrolytes, all that will go out of the body once this fluid is drained. Then you have hemodialysis, which is a one that you will more likely see in a hospital setting. Not to say that you will not see peritoneal dialysis. You will see peritoneal dialysis in the hospital, but not as common as your hemo, which we call hemo. This is a machine that is equipped with a semi-permeable filtering membrane, or what we consider an artificial kidney, because really it's an artificial kidney. It's removing all the waste products and additional excess fluid from the blood. In the dialysis machine, diacylate fluid is pumped through one side of the filter membrane, which is called or considered your artificial kidney, while the patient's blood passes through the other side. So the process of diffusion and osmosis and ultrafiltration will clean the patient's blood. Then the blood returns through a special catheter. Either it can be an AV fistula or hemodialysis catheter or a graft. Then this goes back into the body once it's already been cleansed. And you will go more into this when you do intermediate med-surg. So what are the indications for dialysis? There's a few things here. First off, renal failure that can no longer be controlled by conservative management. Conservative management would be diet and medications. And this is usually to correct electrolyte abnormalities, because the electrolyte dysfunction is what can be a big problem with these patients. If they continue to have worsening uremic syndrome, and because we said they're going to get nauseous, they're going to be vomiting, they're going to have neurological changes, and can't even have pericarditis. If there's a severe electrolyte and fluid abnormality that cannot be controlled by simpler methods, hyperkalemia, like I said, and pulmonary edema, these two, hyperkalemia, if someone has high levels of potassium, they can actually go into a cardiac arrest. Their QRX complex will widen, will eventually flatten out, and your patient will code and die on you. And pulmonary edema, because you have too much fluid, and this fluid is going to back up into your lungs and cause you to have a pink frothy sputum, and that's what it's very classic for pulmonary edema. So what do we do? What are some of the medical interventions? Well, there's surgical, there's medical medications, and there's diagnostics. With surgical procedures, there'll be a retention of fluid intake, which that's usually will lower urine output. And then stress causes fluid retention, or stress can also cause you to go too many times too. It's either or. There's medications that can cause urinary retention, cause urgency and incontinence. Medications can change the color of the urine. So if you ever have a patient that you give pyridium to, if you've administered that medication before, you know that it's going to change the patient's color to a very dark orange. So you must educate your patient so they don't get worried and end up in the clinic. So if someone has anesthetics or any form of narcotic, this is going to slow the glomerular filtration rate. I'm actually going a little bit back into surgery. So that is going to reduce the urine output. These drugs will affect the sensory and motor impulses that will travel among the bladder, spinal cord, and your brain. So patients, they're unable to sense the fullness of their bladder and initiate the urinary micturition. Things such as spinal anesthetics, like women when they go in to deliver a baby and will get a spinal, they need a catheter because they're not going to sense the urge to pee and their bladder is going to overfill. And other surgeries of any surgery having to do with your lower abdominal pelvic structures will impair your urination because there'll be some trauma to the surrounding tissues. So after returning from surgery involving the uteral bladder or any kind of urinary kind of surgeries, your patient will routinely have a urinary catheter. Medications that affect indirectly or indirectly can contribute to urinary dysfunction, such as antipsychotics, depressants, calcium channel blockers can cause urinary retention and overflow continence. Then you have your alpha antagonists, diuretics, sedative hypnotics, opiate analgesics, ACE inhibitors, and histamines can cause urinary incontinence as well. Anti-Parkinson's medications also cause urinary incontinence, and these medications we know they're already usually are prescribed to the older population, and they already have impairment as it is due to age, and we're going to talk about that as well. Other things, we talked about medications and we talked about pyridium, but there's also a medication that causes a green or bluish discoloration, which is your amitriptyline. Levodopa also discolors urine either to brown or black. There's chemo drugs that also change the color of the urine. Then any kind of dyes. If your patient is going to have a procedure that involves dyes, it's important to prior to these procedures, they're going to have to limit fluid before the test. A restriction in fluid intake will usually lower the urine output, so they need the dye to stay in. But after, the patient has to drink a lot of fluid because they want this dye now to be excreted. The patient may have some difficulty voiding or may have a red or pink urine caused by trauma. So it's important to make sure you monitor these patients carefully. If you've had a patient that went in for a procedure like cystoscopies and things that may possibly require some dye, because some of them will have reactions to this dye. So it's very, very important that you monitor these patients closely. Okay? Alterations in urine elimination. As urinary retention progresses, retention With overflow develops, bladder distension is very apparent. Usually, with retention, patients will avoid small amounts of urine 2 to 3 times an hour with no relief. So that's a very clear sign that there are some retention problems going on. So you need to evaluate this. This is something you want to report to the doctor because he might want you to do a post-residual catheterization. And with the post-residual catheterization, they give the doctors a clear idea that there is retention going on because your patient just peed a really tiny amount and you put that catheter in and here you go, you got 200. So that's a very clear sign of retention. Urinary tract infections are commonly caused by UTI. There are some candidiasis types of bugs that can cause urinary tract infection, but commonly it's E. coli. And women are more susceptible to UTIs because we have a short urethra and the proximity of the anus is closer in our anatomy. Usually, if someone is having dysuria, they're going to be having some burning during urination because urine passes through an inflamed tissues. An irritated bladder is known as cystitis. Itis is usually inflammation. Irritation of the bladder and urethral mucosa causes hematuria. So you'll see a little bit of blood in the urine. If infection spreads into the kidneys, the patient will have pyelonephritis, inflammation again, itis. With symptoms, they'll have flank pain, tenderness, fever, chills. If the doctor was to palpate the kidneys very quickly, or not just palpate, they can also percuss, the patient will have severe tenderness to the area. Urinary incontinence can temporarily or permanently or continuous. Let me start again. Urinary incontinence can be temporary or permanent. It just depends on what's going on with your patient, their age, if they're having problems with movement, mental capacity. At times, if this continues, patients will usually have to end up with a stoma. And this may be necessary if there's trauma, cancer, any kind of fistulas, chronic cystitis. Then they'll do urinary diversions, which is called ileo loop or a conduit, continent pouch, or nephrostomies, which many of you might have seen some of these alternatives for urine output. When caring for the older adult, it is important that you provide frequent opportunities for your older patient to void, partially because the anatomy of the elderly is different. They have smaller bladders. Not smaller bladders in general, but they have a small bladder capacity compared to younger adults. So it's important to encourage your elderly adult to empty the bladder before and after meals and at bedtime. Discourage them from drinking any type of coffee and tea or brown cola and alcohol. All of these are diuretics and they're going to cause your patient to have increased urinary frequency, and that's not good when your patient may have impaired movement because they can fall. So have some caution even at nighttime. Make sure that you discourage this from occurring. However, do give your patients cranberry juice as long as it's not contraindicated. As many of you know, cranberry juice prevents urinary infection. And what happens with cranberry juice and vitamin C is because it helps acidity in the urine to decrease bacterial infections. So the higher elevations of acid makes an unpleasant environment for the bacteria, so they will not multiply. Restrict fluid intake does not decrease urinary incontinence severity or frequency. Whenever possible, avoid the use of catheters. If one is necessary, don't use it longer than you need to. Try to take the catheters out as soon as you possibly can. do know that incontinence is not a normal part of aging, and make efforts to assess incontinence and provide interventions to promote return of continence, especially for the way they feel. Your older adults do not want to be incontinent. They do not want to bother you. So if there's things we can do to help them, then we need to do that. Quick quiz. Let's read this question. So a healthcare provider may suspect that a patient is experiencing urinary retention when the patient has, as mentioned before, small amounts of urine voided 2 to 3 times per hour, because they're not fully clearing their bladder completely, emptying out their bladder, so they're going to have more episodes of urges to go void. Here are the different types of urinary diversions, and I will let you look at that in your book. Some nursing knowledge that you need to know. It's very important that we have infection control methods in place to avoid UTIs from occurring. So the urinary tract, as mentioned earlier, is sterile. That's why anything that goes in there has to also be sterile. So the use of infection control principles will help us not spread UTI. Increased urine intake results in increased dilated urine formation, which reduces the risk of urinary tract infection. Growth and development factors will determine the patient's ability to control the act of urination across the lifespan. When dealing with infants, children, and elderly, they're going to experience problems with urination. The young need to recognize the need. The elderly need to deal with decreased function that accompanies aging. As mentioned before, they have psychosocial events because they lose their independence. When there's weak abdominal and pelvic muscles, that also impairs the ability of urinary sphincter to maintain tone. Immobility, muscle damage during vaginal delivery. Some women have had some urinary problems after they've had like a traumatic vaginal delivery. Psychosocial issues will affect the patient. Body image, self-esteem roles. Males stand and females sit. That's why we have problems when we have our little older gentlemen or even younger guys that don't have the best in balance with their feet, but yet they want to stand up, so they're at high risk for falls. Don't forget culture. There's culture considerations. Urinary problems may not be treated in the Western tradition. Culture may also indicate or culture may dictate how and when a patient will urinate. In some cultures, some patients will actually urinate in a squatting position. So it's important to try to give them cultural competent care whenever possible. Okay, now as far as the nursing process and assessment, we do need to take a good nursing history. We need to know what type of patterns of urination do they have. Do they void every 4 hours, every 6 hours? And then what kind of symptoms are they having? Are they having any kind of burning, any kind of changes in color, and any types of factors that can affect their urination? We need to know all this. As far as environmental factors, medication history, any kind of problems with muscle tone, any kind of current surgeries or diagnostic tests that can cause any issues with that. So it's important to get that good assessment done. If you need to collect a urine specimen on a child, there's things that you need to keep in mind. It will usually work well if you give your child fluids 30 minutes before you need the specimen. You need to remember that you need to use terms that the child is going to understand. And a young child will have a hard time voiding in front of unfamiliar places and unfamiliar people. So it's important that you involve the parents into possibly trying to collect a urine. And you also need, there's special devices for infants and toddlers that are not toilet trained that you can use. There's these little clear plastic bags that you can put around the children's little meatus. Do not obtain specimens by squeezing urine from the diaper because this is not going to be accurate. So don't use that type of method. Here is a quiz question. So a young girl is having problems urinating post-op. You remember that children have trouble voiding in bathrooms other than their own? Not necessarily. Is the girl able to void in a urinal? No. While lying in bed? Well, lying in bed, it just changes the posture on how you void, so it's going to be a difficult position. But we do know that they're not able to void in the presence of people other than their parents. So the answer to this is D. For the physical assessment, you are going to use the nursing process and critical thinking as you are doing your physical assessment. Make sure that you're providing good clinical decision-making techniques because you're approaching this patient as an individual and you're going to implement individualized interventions. Make sure that this patient is being thoroughly assessed and any type of clinical findings that are analyzed are discussed with the physician. Make sure whatever you do, you're always providing safe nursing care. And if you do successful critical thinking, you are going to use techniques such as synthesis of knowledge, experience, because you're going to, through experience, you're going to know what type of information to gather. And clinical judgments require you to collect necessary information, analyze the data, and anticipate what kind of decisions are going to be made. As far as your laboratory and diagnostic test, you're going to make sure you look at that. So if you know you sent a urine specimen, make sure that you're looking for the urine specimen results that the lab should have for you within a certain amount of time. Make sure you follow through with those type of things. Here's a little bit more on physical assessment. In order to identify a problem in the urinary tract system, you want to gather information. You want to gather data to formulate a care plan. You want to use scientific and nursing knowledge. You're going to have to conduct a nursing history, a physical exam, assess the patient's urine, which you would have sent to the lab, any kind of examinations, diagnostic tests such as ultrasounds or things like that. So you're using critical thinking as you're synthesizing all this information. You're going to look at the skin and the mucosa. You're going to look for dehydration signs. Skin turgor. Remember, checking skin turgor gives us a good view of hydration status. Not necessarily for your older population, but for your younger adult population. Bladder, we know where it sits, so it's we can always ask the patients if they feel tenderness. We can palpate or percuss with the urethral meatus. We can look at the urethral meatus and we can look for any kind of drainage or lesions. If there's drainage, that usually indicates an infection. And the male meatus has a small opening in the tip of the penis, so you want to inspect that for any kind of lesions, inflammation. And if the patient is uncircumcised, you want to pull that foreskin back so you can do a clear assessment on the patient's anatomy. As you are assessing the urine, you're going to be looking at intake and output. Intake and output is very important. There's times that you will have physicians write strict urine output because this is how they're going to manage the patient's care. They're going to look and see, do they need to increase volume? Do they need to decrease volume? Etc. So always remember, and I'm sure you were taught this before, that every patient should have at least 30 mLs per hour. If urine output is decreasing, It is something that will require you to do further assessment because we know that 30 mLs should be the minimal amount. The color of the urine also makes a difference. If urine either pale, straw, or amber, um, urine that's is more concentrated in the morning. And then we talked about how medications can change the color. Um, Foods as well can change the color. Beets, blackberries. When a urine is dark too, like it's amber, a lot of times if someone has a liver disease, it can be signs of bilirubin. And stagnant urine will sometimes have a strong ammonia odor. And if there's a sweet, fruity odor, it can sometimes be seen with diabetes or starvation. And urine specimen collection plays an important role because it's we need to teach our patients how to give us a proper urine specimen. So when we need a clean catch or a sterile timed, they'll be able to provide us with a specimen, and once it's sent to the lab, we can get diagnostic information for it. So specific gravity is the weight or degree of concentration of a substance compared with the equal volume of water. You will have times that your doctor is going to order a specific gravity on patients. And going back to urinalysis, it's going to be based on hospital policy and procedure, how they have specifics on how to collect a urine sample, but most of it are pretty standard across the board. That they're going to want a clean catch usually. Sometimes they want a specimen directly from a catheter when it's brand new, or some not even if it's brand new, they'll want you to get a specimen out of the catheter. When it's collected properly, it'll be a clean catch because a clean catch will have already the first stream, as soon as a person voids, will have cleared some of the bacteria out of the urethral meatus. And urine culture has to be sterile or clean voided urine sample. It usually takes anywhere from 24 to 48 hours to have a culture show us the findings, because they have to put whatever they get into a petri dish and see what grows on it. And this is important because we need to determine what the patient is sensitive to and which antibiotic will be more effective. Non-invasive procedures can be like your KUB, which is kidney, urine, bladder. Also a CT and IV pyelogram. Once again, anytime you hear anything like intravenous pyelogram, they're usually going to use dye. Then you have invasive procedures, which would be your cystoscopy or your arteriography. And remember that each examination has a specific indication and use. We need to educate our patients. And we also need to know if they're allergic to dyes. We need a consent form for these procedures. And if you ask them if they're allergic to shellfish, that'll be a good indication if they'll be allergic to dye. When you drain urine from the bag, make sure that you have measured it in a graduate cylinder and you're putting it in the proper receptacle. Remember, with your Foley catheter, you had to empty out your Foley bag prior to removing the catheter. The container needs to be rinsed after emptying, and the tubing that drains the bag securely clamped and cleansed with alcohol before it is put back into the holder. Do not allow your bag to touch the floor, and make sure that you're emptying it out at the proper amount of time. If someone has anywhere from 2,000 to 2,500 cc's a day, that usually means there's polyuria. And if someone has output less than 30 for 2 consecutive hours, remember, it's usually a cause for concern. On average, most individuals will void anywhere from 1.2 to 1.5 liters of urine. And as you collect a urine specimen, make sure you've cleansed that port section, allow it to dry, and then you can grab your syringe and collect your specimen. And then here is your chem strip, which is a quick screening tool that is used usually in the clinics and ER. Just compare it to the vial to look for color changes, and it'll tell you certain information in regards to your patient's urine. Here's just a little bit of nursing diagnoses that can be used on different patients. So when you're implementing certain things, as education plays a huge role, we want to make sure that we're educating our patients about any changes in their voiding habits. We need to know if they're having any kind of difficulty. We also need to know if they have certain ways that they void, certain positions they like to use. Also, we want to maintain their elimination habits as best as we possibly can. We want them to, we want to include their habits into our plan of care, and because if we don't, then we might run into problems related to urination. Always make sure that you're educating your patients to drink enough fluid intake as long as it's not contraindicated. And encourage patients to wait until urine stops flowing or to attempt to void again. This improves bladder emptying. One of the most important considerations to prevent urinary infection is taking fluid intake. And we also need to teach them things to prevent infection, such as proper cleansing, having women clean from front to back. This is just a diagram showing you the different kind of urinals that are available. This slide we're going to cover some implementation. Keep in mind that patients will require time to void. You cannot request a urine on demand because might cause some stress to the patient. We know stress may cause a little bit of retention, and they may not be able to give you the specimen. Give them at least 30 minutes so they can have time to relax. Some of them are going to need privacy. Some of them may need a commode or bedpan to try to get the specimen, which might cause a little bit of discomfort. Drug therapy, given alone or with other therapies, will sometimes help with problems of incontinence or retention. The bladder is innervated by the parasympathetic nervous system, so there's drugs that will block the muscarinic receptors that suppress the bladder contractions and will reduce incontinence caused by bladder irritation. When the bladder empties, the trousseau muscle contracts in response to the parasympathetic stimulation, and incomplete bladder emptying results from impaired intervention or weakness of that muscle. Catheterization of the bladder, we actually did this in lab, so it's either going to introduce a latex or latex free, and we also have silicone plastic tubes into the urethra that's going to go into the bladder. And the catheter, we know, provides continuous flow of urine when the patient is unable to go on their own. When talking about catheterization, the insertion portion, we know that we can do what we call a straight cath. A straight cath can be a ×1. It can also be intermittent, or we can also have the indwelling, which we practiced in the lab. A catheter drainage system is a closed system because we do not want our patient to get a urinary tract infection. And we do need an order to insert a catheter into our patient. That's why we always have to check a doctor's orders. We must use sterile aseptic technique. Once this catheter is inserted, try to keep this system closed. You do not want to introduce or introduce any bacteria or do anything that can possibly increase the risk of infection. You want to minimize the risk of infection at all cost. When you're doing catheter care should be done at least 3 times daily or as needed. Need to check your facility's policy and procedures for catheter care, but on average it's about 3 times a day, every 8 hours, or as needed. All patients with catheters should have a daily intake, if it's not contraindicated, of at least 2 to 2.5 liters. If a catheter irrigation is needed, it is very important because we do want to maintain patency of our urinary catheters. However, we do know if we irrigate, we must have a very logical reason why we're irrigating this Foley. Things such as blood, pus, which if there's pus usually will indicate an infection, any kind of sediment that is present in the tubing usually means there's sediment up in the bladder, which can cause your Foley catheter to become obstructed. So that's when you would have to irrigate. And we know that an indwelling catheter stays in the bladder for an extended period of time. If there's a choice between intermittent catheterization, intermittent catheterization will not cause infection such as an indwelling catheter would. When you're removing the indwelling catheter, make sure that we check on the patient at least 2 to 4 hours after this has been removed to make sure their normal bladder function has returned, and make sure you're preventing any kind of trauma to the urethra area. These are 2 types of catheters, and that's just a picture to show you, and there's more information on this in the book, and I'm not really going to ask you much on this. It's just mainly for your knowledge because it's very specific, and I want our information to be a little bit more general. Urinary drainage system and organisms. Here's just showing you a diagram on how the catheter shows a balloon and how it keeps it in place. It's important that we always follow good hand hygiene techniques. Do not allow your drainage system to touch the floor or any contaminated surface. Only use sterile technique when handling this catheter because we know it's a closed system. And make sure that the patient has a separate receptacle for measuring urine to prevent cross-contamination. Prevent pooling of urine in the tubing, and if there is your urine output decreases, let's say your patient's having good urine output, 30, 40, 50, 50, 50, 60, then all of a sudden 0, 0, then you need to go in and you might need to milk your tube or manipulate your tube, raise it and lower it to allow gravity to pull whatever urine might have been backed up into your drainage bag. And if your patient needs to get up, they need to ambulate, or they need to walk, make sure that you drain all the urine from the tubing into the drainage bag, and might be a good idea to empty it as well. Avoid prolonged kinking or clamping of the tubing. It's important to empty the drainage bag at least every 8 hours. That way you keep a good track of your urine output. And as mentioned before, encourage fluid intake if not contraindicated. And as soon as the patient doesn't need the catheter, take it out as soon as you can. This is a diagram just showing you how you would apply a condom catheter. Sometimes doctors do not want to use a indwelling catheter, and as we have gone over this chapter, we know because of the high risk for infection, so sometimes they'll opt to do a condom catheter. It's a good method for men that are incontinent or comatose but may still have spontaneous bladder emptying. This is usually a soft latex sheath that we put over the penis. Some of it will come with some self-adhesive. And make sure that if it is latex, you would assess a latex allergy prior to. And this is something that can be delegated to your nursing assistant personnel. Make sure privacy is provided for this. And make sure that the skin of the penis shaft is intact and free from swelling, redness. You may have to do some care before you apply this catheter. And ask for assistance if the nurse assistant personnel is uncertain how to apply that adhesive strip that secures the condom catheter. Some of them actually have a little strip. So it's important to ask the NAP, nurse assistant personnel, if she's comfortable with this method, which will require the tape, because we do not want the tape to be too tight around the penile area. And here's actually a diagram showing you how the tape would be secure. Although you will very seldom see this type, you will more likely see the type that has some self-adhesive and rolls right onto your patient's penile area. This is another diagram just showing you how you can attach this condom catheter to a bag. Some patients will go home with leg bags. Sometimes they will have an indwelling that will be connected to a bag as well. The condom catheter does need to be changed on a daily basis. And each time it's changed, the penile area needs to be assessed thoroughly. Circulation and all that needs to be assessed. This is just an external urinary device for people that will have ostomies, ureterostomies. And as far as restorative care, we want to restore as much as we possibly can, have these patients go back to what they were doing prior to. Showing them pelvic exercises that helps. Kegel, that's known as your Kegel exercises, that will give strength to the pelvic floor muscles. And bladder retraining. The goal for bladder retaining is to reduce voiding frequency and hopefully bladder capacity. And in order to do this, there's different things we can do. There's one where you can actually clamp your Foley and unclamp. So when we clamp the Foley, because especially if someone has had a chronic catheter in, the bladder has lost some of the muscle tone that it needs to help with emptying. So we want to retrain this muscle. So we're going to clamp and unclamp the catheter to allow the bladder to, or the muscle to feel that distension again and activate all the systems that help with natural micturition or voiding. And as mentioned before, some patients will have to self-catheterize because they have lost ability or the sensation to be able to do this naturally. And then keep in mind that patients with urinary alterations are uncomfortable sometimes, and frequent or unpredictable voiding if they're having dysuria or painful distension. Make sure that you are assessing all these things, and make sure that our patient is always clean and dry. A lot of incontinent patients will be sitting in a wet diaper, but we want to prevent that because we don't want any irritated dermatitis to occur on our patients. And after you do all these wonderful interventions, you're going to evaluate. You can go back and see, and if your interventions worked. If not, then we need to see what else we can do to change what we've done to improve our patient's goal. Here are some safety guidelines that it's important for you to follow. Always follow the principles of surgical and medical asepsis when performing catheterization. We know that there's a high risk of infection for this, and hospitals are being mandated now to prevent urinary tract infections because it's being considered negligence from hospitals if patients develop urinary tract infections that are related to catheters. There's protocols out there now. CAUTI. CAUTI is what they call it, catheter-associated urinary tract infection. So they have different protocols they do. Be such as keeping the para area clean, providing urinary care every 3 hours, making sure that you're using aseptic technique anytime you're handling this catheter, using aseptic technique to put it in, and making sure that the bag is not on the floor and that the bag is up, and just different things, and making sure that there's no impairment in the drainage system itself. So if you notice, like an example I gave you, if all of a sudden there's no more urine output, then you need to go back and reassess your catheter itself. Since these catheters, many of them are latex, make sure that you are evaluating for any kind of latex allergy. And as mentioned, you do have an option of silicone now, so there's the silicone catheters that can be used as well. Identify your patients that have allergies to betadine, and if they do have an allergy to betadine, then a good alternative is chlorhexidine. Many hospitals now have chlorhexidine that can be used because, of course, there is these allergies to the betadine. And here is my little quote. So I'm not telling you it's going to be easy. I'm telling you that it's going to be worth it, because when you are all done and after all this hard work that you do, it'll be worth it for you. If you have any questions, please ask me in class or email me any questions you have.